is we have a 69-year-old female who was evaluated for 3 days of muscle cramping, weakness, and fatigue, and she has this BMP.
You're not going to give us a glucose value?
Nope. So her sodium was 123, potassium was 3.2, chloride 73, bicarb 38, BUN 72, creatinine was 1.8. So what sticks out to you guys?
Okay, Mario.
Well, I would also like to.
Rafael, we'll let you join in, because as much as I tried, I couldn't get any of the women to join. So Mario, you were starting, and then I, as usual, rudely interrupted.
No problem. I think a couple of things jump out to me. He has a pretty severe hyponatremia, and also low potassium and low chloride, but interestingly, pretty high bicarb. I was wondering, if I had to choose one of these parameters, I would probably work up the first hyponatremia, because I think I can handle that better. And for that, the glucose would be important to rule out stuff like and if it's a hyposmolar or hypotonic hyponatremia, or if it's an iso or hyperosmolar.
Right. I love the way you're going at this, Mario. The sodium certainly is a reason for fatigue, probably cramping, and definitely weakness. 123 is enough to cause problems. Then you also mentioned that she's hypokalemic. You wonder whether it's real hyponatremia, because the guy presenting it to us hid the glucose from us, and that has to be a clue. Why would he hide the glucose if it was normal? So that's concerning. Rafa, what else do you notice?
So just like you told us, I think the first question is just, is it true or false hyponatremia? So if it's false hyponatremia, we could think about increased proteins or increased lipids or increased glucose, like you just said to us. And this patient also has hypokalemia, so we could think about loss of potassium in the urine, or maybe increased influx. For example, if this patient is on albuterol, so it could be interesting to see the list of medications. And also, I see a pattern, like this patient has hypochloremic, hypokalemic, metabolic alkalosis, if I'm not mistaken. So I would ask if this patient is vomiting lately, so, and also there is this increased BUN and creatinine. So I'm thinking about dehydration, which could explain also the hyponatremia. So those are my thoughts right now.
Okay, so I'm going to be pedantic. And if you don't know what pedantic is, I'm going to say something that is true, perhaps a little bit overboard, but it is a teaching point. This patient cannot be dehydrated because the patient has a low sodium. By definition, dehydration is a high sodium, high osms. Patient is probably volume contracted. Whenever I see this high BUN to creatinine ratio, I ask myself, could there be a GI bleed? Because when you have an upper GI bleed, you break down a lot of that blood into urea nitrogen. So the highest BUN to creatinine ratios you'll see is with an upper GI bleed. It's part the volume contraction, part the breaking down of the hemoglobin. A few people wanted to get a VBG. It's certainly possible that this patient has a respiratory acidosis. We don't have a history yet of COPD, but if the patient has COPD or has a reason for hypoventilation, then this might be compensation. But I'm more than happy to get a VBG if we can, just to document that we really have a metabolic alkalosis. If we have a metabolic alkalosis, then we can go through our algorithm for how to work up a hypokalemic metabolic alkalosis. Let's see. What about this level of sodium in the setting of hyperosmolar hyperglycemia? Wouldn't you call it dehydration? Yeah, you could possibly have dehydration if the patient had a high enough glucose. But the point about the bioendocratinine is really volume contraction. So this patient could be dehydrated, probably is not, but we don't know that. So do we have a VBG on this patient, Sean?
Yeah, we have a VBG. So her VBG, her pH was 7.5, and her PCO2 was 52.
So back to Mario. I think we have the acid-base problem. Now we just have to find out what's causing the acid-base problem. Do you agree with that?
Yeah, I think the VBG just confirms that it's going the same direction, the pH and the bicarb. So that I think it's.
So how do we think about hypokalemic metabolic alkalosis?
I think I learned from you to think about hypokalemia in terms of checking the acid-base status. So I would approach it from a metabolic alkalosis standpoint. I would divide into, is this chloride sensitive or chloride resistant? Meaning if it's I think we define that in terms of urine chloride. I would, in those two buckets, I would think in the chloride resistant bucket of hypertensive, if the patient also have hypertension, of mineralocorticoid excess syndromes, and other bucket would be Bartter and Gittleman and other tubular disorders. And in the chloride sensitive, I would be thinking about either GI losses, for example, vomiting. I think villous adenomas can also cause that, and on renal losses, especially in the patient, especially if the patient is on a diuretic.
Okay, so let me rearrange that. You said everything, but I want to put it into buckets. I always think of the low urine chloride first, and you named a bunch of low urine chloride activities. That's the classic vomiting, NG suction, overdiuresis, and then you added villous adenoma. That was interesting. Why'd you add villous adenoma?
I learned, I think from in Twitter I saw, I think it usually villous adenomas cause hypokalemia, but with a metabolic, I think it's usually with a metabolic acidosis because it secretes hydrogen chloride. But I think there's atypical causes. I think I saw a tweet from Dr. Joel Top saying there's atypical villous adenomas. I'm not sure. I'm pretty sure it's pretty rare, but I just started reading down my differential.
And I think you're right. I think usually we think of stool losses as causing a normal gap acidosis because usually stool is basic. And what you're saying is there are some very unusual causes of diarrhea that you actually lose chloride and develop metabolic alkalosis rather than a metabolic acidosis. So that was the loss of chloride-rich fluid, and then the other one was anything that disrupts the aldose system, and so you included aldosteronism. Because there's a low sodium, we probably we wouldn't include Cushing's, because Cushing's should not give us a low sodium. Addison's can give us a low sodium, but that wouldn't explain hypokalemia. So because we're talking about increased aldo. We're talking about licorice. And remember, that's real licorice. And what we like to say in the US is like real British licorice, not the fake licorice that we have in the US. Our licorice is horrible. But there's also, I've read cases about licorice oil. People will go to health food stores, and licorice oil is recommended for certain things by people who know nothing about medicine. And so people will take extra licorice for that. Licorice is also in some chewing tobaccos, and they have cases reported like that. And then you mentioned the inborn errors, such as Barter's and Gittleman's, as being possibilities. I think you can also get it with the other. Can you get it with the other potassium sparing diuretics like amiloride and triamterene? I think you can. So we need to know more about this patient. Is the patient clinically volume contracted? We're not just going to go with the urine chloride, but we'll try to get a urine chloride and learn a little bit more about the patient. Do we have the glucose yet, Sean?
Yeah, so I can give you her glucose, and it was 118. So you thought about it a lot, but
okay, so that's helpful, right? So now we know that it's real hyponatremia. Now, what's our best hypothesis for the hyponatremia right now, Rafa?
So for me, I think the common things being common could be vomiting.
Okay, so vomiting is a specific example of what underlying construct?
I'm sorry, could you ask
Okay,
again?
so I probably didn't say that very well. So Kushal has answered it in the chat. So hypovolemia. So if you're hypovolemic, why do you get hyponatremia? This is actually, once you hear it, it's a very, very simple question.
Because you are turning your ADH on and you're absorbing water.
The strongest stimulus for ADH is volume contraction. So you get volume contracted, you drink in fluids, but your fluids are more dilute than your urine, and so you drive down your sodium, and that is a classic hypokalemia. So now we have increased BUN to creatinine. That makes us think of this. We have decreased sodium. That makes us think of it. And we have a hypokalemic metabolic alkalosis. So, oh, this is an easy case. This lady's probably just vomiting, right? Of course not. We're presenting it today. That would be too easy. But so we'll get a history of vomiting. Do we have a urine chloride? She denies vomiting. Do we believe her?
her urine chloride was less than 20.
Okay. So Mario, you wanted the urine chloride, right? Or did Rafa, or did you both want it?
I think both.
Okay, so that now we're in a quandary. So now we're gonna have to look to figure out if she's really not vomiting. Now, at 69, she's probably telling us the truth. So this is for Dhruv. You could easily see this in a teenager with anorexia nervosa or bulimia, right? Mm-hmm. Right, Dhruv?
Mm-hmm.
So
any of the purging disorders.
Yeah. So that would be a possibility. Zoom user, I have no idea who Zoom user is, but Zoom user wants a urine sodium, urinosum, and serum uric acid. So Zoom user, why do you want that? Whoever Zoom user is. The mystery of Zoom user. Is Zoom user typing right now? Hyponatremia, ADH, and RAS. RAS system. Okay, so the urine sodium is not going to help us as much in this situation as urine chloride because of the metabolic alkalosis. So I'm not sure how the urine sodium is going to help me. I think the urine osms and the serum osms will help me a lot. The serum uric acid might be a clue to inappropriate ADH, but right now we think we're dealing with appropriate ADH, which is sort of different. So do we have any more urine studies, Sean?
Yeah, sure. I can give you a urine sodium. It was also less than 20.
Okay.
And her urine osm was 512.
Right. Does that really help us? Is anybody surprised that her urine osms are 512? Now, we could have done a urinalysis and just shown she had a high specific gravity. Had they done a urinalysis?
They had, and it was elevated. It was 1020.
Okay, so somebody has mentioned, several people have mentioned that you can take the last two digits, so 20 here, and multiply it by 3, multiply it by 30, and estimate the urine osms. So the estimated urine osms from the urine specific gravity would be 600, they're 512. That's good enough for what we're trying to do. This means the kidneys are working well. This also says we can take Aldo and licorice and Barter's and Gittleman's all off the table. Somehow this patient's getting volume contracted. We have to figure out how she's getting volume contracted. And while she's getting volume contracted, so is she on a diuretic?
So she completely denies any sort of diuretic.
Any medications at all?
So we hadn't mentioned that she'd been hospitalized for kind of similar symptoms a couple times in the past and had very similar lab values. And so she's on some weird medicines at face value. But what she is on is 1 gram of sodium chloride TID, which she hates. She's on 20 milliequivalents of potassium TID, and then no NSAIDs, no herbal supplement, denies laxatives, and definitely denies diuretics.
Okay. So can anyone explain why this lady you would give sodium chloride to rather than lactated ringers? These days we almost always give lactated ringers, but this lady we would not give lactated ringers.
Well, she has a low chloride, doesn't she?
She has a low chloride, and so Alex Smith asked the reason we take Barter's and Gittleman's off the differential because of the urine electrolytes. That's correct. That's correct. They would have had higher urine chlorides, and this is one of the better Curious Clinician podcasts, is why chloride is so important in correcting metabolic alkalosis. So metabolic alkalosis is almost automatic that you go to sodium chloride. You're going to give her potassium also. You're going to be careful about all that. At 123, you're a little bit nervous, and I'd try not to raise her sodium too fast. So I like to stay at about 6 milliequivalents per 24 hours. No one has been able to have a randomized controlled trial that shows exactly what the right rate of increase is. But the more I read in the sodium literature, the more that many of the experts are leaning towards an even slower increase over 24 hours. Now, if we think she's symptomatic, we might treat her faster initially. Does she have any of the symptoms that would cause us to give 3% normal saline and get her sodium up faster? So do you have any idea about that, Mario?
I think I usually associate hyponatremia with neurologic symptoms like headache, confusion, nausea, vomiting, convulsions, even. But I'm not sure I'm seeing that picture here.
So I like your thought process here. Seizures and altered mental status are really the two main reasons that you would give it. There's one other obscure reason that I've never seen, but I've read about, and that is flash pulmonary edema, and that's neurogenic induced pulmonary edema. So if somebody like this who didn't have, and she didn't have heart disease, came in with pulmonary edema and a sodium of 110, you'd give 3% normal saline in boluses, a couple of boluses to see, and paradoxically, that would get rid of the pulmonary edema. That we don't have to worry about that particular case because she doesn't have those symptoms. So she denies all this stuff. So let's do a review of systems. I mean, we're sort of lost. If she's not vomiting and she's not on a diuretic, where's she losing her volume? Does she correct with volume, Sean?
Yeah, so pretty much every time she gets fluids, she got salt tablets, potassium repletion, and her symptoms resolved and her BMP resolved, and she went home after a couple days.
Right. And what did they blame it on before?
Poor documentation, but they thought that maybe she was taking diuretics or just had poor PO intake for some unspecified reason.
Can we get some more history from? Let's just do a review of systems. You know, does she have? Do we have any past medical history other than she's been having these recurrent abnormal BMPs and feeling horrible?
Yeah, so in terms of past medical history, she really doesn't have any, but she really hasn't, outside of these hospitalizations, had much medical contact, and hasn't, somebody in the chat had asked if she had had a colonoscopy, had not had one before.
So was it Mario or Rafa who wanted, who was worried about diarrhea? Is that you, Mario?
Well, I think I mentioned the villus adenoma, but she denied also diarrhea, right?
No, she hasn't denied diarrhea. She denied vomiting.
Okay. Oh, okay.
So if you're right that's an unusual complication of villus adenoma, then I mean we're really sort of frustrated right now. I'm frustrated right now. I'm frustrated because all the routine things that would explain a hypokalemic metabolic alkalosis, 99% of the time, this is a slam dunk easy thing. And so what Alex Smith says is, could this be a chloride diarrhea? Now, there is a congenital syndrome, and I think it's seen in Finland, of chloride diarrhea, but I think there are other chloride diarrheas. I thought that I saw a case once of lactulose-induced metabolic alkalosis, because one of the ways lactulose supposedly works is to cause an acid stool so that you can bind ammonium. Whether that really is a mechanism that works, I don't know, but I thought I saw it one time. I wrote that down as the reason for metabolic alkalosis one time. So the question is, is there diarrhea, and is it an osmotic diarrhea that is chloride rich? That would be wild. That would be wild. And how are we getting to this? We're using the basic Sherlock Holmes philosophy. And how many people are familiar with Sherlock Holmes? Are people who don't have English as their primary language, has everybody heard about Sherlock Holmes? Kushal says the game is afoot. Good. And one of the things is one of his famous quotes is, when you exclude when you've excluded everything that's possible, and there's still something that's virtually impossible, but everything else has been excluded, then we have to think about the impossible. And the impossible here would be a chloride diarrhea. If we really believe she's not vomiting, and we have no clue that she's vomiting, we have no history that she's vomiting. No one has seen her vomit. Is she anorexic looking at all, Sean?
I wouldn't say she's anorexic looking,
Okay.
no.
So
But
has she had any diarrhea at all?
so initially she says no,
Okay.
but the nurse did page you during the night that she seems
I
to
hope the
have a lot
nurse paged me at 3 a.m. because that would remind me of my internship.
yeah. Well, this happened during your internship then. She noticed a lot of basically just mucus in the toilet and wanted to make sure you were aware.
Okay. So Rafa, what do you think?
To be honest with you, I'm lost. I have no
Good.
idea what's going on.
Good. So this case is absolutely ridiculous. But I think we're getting there slowly but surely. So Mario, now that we have this mucus, what do you want to do?
Well, I think we've ruled out all other major causes of volume loss. I'm not sure if we can study that mucus to see what it's composed. Or I know, for example, at least in villocyanomas, they're usually all located on the rectum, not on the colon or the
Right.
intestine. So I'm not sure. Maybe we could do a colonoscopy to see if there's something we haven't noticed.
Yeah, so if we were smart enough to think about villus adenoma, I think you were smarter than me. I wouldn't have thought of that. But copious amounts of mucinous material. Drew had suggested maybe we should get some stool studies and decide whether this is an osmotic diarrhea or secretory diarrhea. That might help us. So did anybody think about that, Sean?
Yeah, so the stool studies were obtained and the stool sodium was 119, stool potassium was 43, and stool chloride was 145.
So Drew, you're going into pediatrics, so I'm gonna pull you out on this one. So most of us have never gotten stool electrolytes. My guess is they do that in pediatrics periodically. How do you interpret that?
Well, I think the one question that I would actually ask, and this may be a question that would be, this is certainly the oldest patient that I would ask this question about. Did you get a sweat test on this patient?
No.
Right, so, and you can get diarrhea from cystic fibrosis, right?
Mm-hmm. That's what I was thinking.
Yeah. 69-year-old woman, I don't think so.
It's not impossible.
It's not impossible. What makes you think of that, and explain that to those of us who take care of very few cystic fibrosis patients? And I'm not saying they're not adults. It's just that in my institution, we actually have a cystic fibrosis service. We have one of the world's experts who's was one of our med-peds residents, who is a pulmonary physician. And so he takes care of the cystic fibrosis patients as they get older, and they're staying alive much longer now. So the stool osm. So what our estimated stool osm is 300 minus 210. It's really low.
It's 43.
What does that tell us? We're getting into a neighborhood that I don't live in.
Low gap usually means secretory, right? Because you're rich on sodium and potassium and other.
So this is low, so it's a secretory diarrhea. So the secretory diarrhea, then we have to figure out why it's a secretory diarrhea. Why do people get secretory diarrhea? Okay, we have people from other countries. Do we have anybody from India? Anybody here from Southern Asia? So Southern Asia, the first thing you'd think of is cholera, right? In the U.S., we have some very nice answers here. VIPoma, TSH, Kushal, I think TSH usually causes hyperdefecation rather than a secretory diarrhea. Has anybody seen something that says that it actually would cause a secretory diarrhea? Okay, let's see. We have giardiasis. I actually had a very interesting woman who had a secretory diarrhea that we finally were able to prove that she had an infection with a bacteria called Aeromonas. And Aeromonas is a freshwater bacteria that can cause a secretory diarrhea. And this lady had diarrhea for 6 months. It's very, very easy to treat that one. And I think villus adenoma has to be on that list for secretory diarrheas. So now we're going to have to do, somebody had carcinoid. We don't have any other symptoms of carcinoid, but I like the thought process. Celiac. Does celiac give an osmotic diarrhea? I mean, a secretory diarrhea? Harsha, can you look that up and give us information? I mean, I know that you can get diarrhea from celiac, but I don't remember it being a secretory diarrhea. It's an osmotic diarrhea. Cesar says that. You can get Aeromonas infection from leech therapy. That's interesting. Thank you, Harsha. Appreciate it. CMV, HIV, TB Whipples. Okay. So now that we have the secretory diarrhea, we'll get cultures. We'll send off hormone levels.
Uncle Bob, if I can say, celiac disease can lead to osmotic diarrhea.
It causes what?
Osmotic diarrhea.
Osmotic diarrhea. I thought celiac was an osmotic diarrhea. So that wouldn't help us here because this is not an osmotic diarrhea.
Yeah, so when it comes to secretory diarrhea, Sipisovirus is this incredible ischemia, as always. It's inside of the chronic diarrhea schema, and they divide into chronic infection, malignancy, inflammation, or motility disorders. Chronic infections being CMV, HIV, TB, Whipples, but also giardia, and malignancy could be mucinous adenocarcinoma, just like we said before, but also NET. Inflammation could be macroscopic colitis, but also IBD. And motility disorders could be autonomic neuropathy and thyroid. And if the workup is negative, we could think about IBS or functional diarrhea.
So does the mucinous material help us?
I think so. Maybe she's losing chloride and bicarb on the stool.
Yeah. So a few people have been asking for a colonoscopy for about, let's see, it's 7:39 Central Time. Since about 7:10, they've been asking for a colonoscopy. Olmesartan-induced enteropathy. Okay. So there's all kinds of things. We don't think she's on any meds that would cause this. We don't have a history. Does she have any B symptoms, Sean? Has she lost weight or anything like that?
No. She's maybe lost like 4 to 5 pounds, but otherwise like no fevers, chills, night sweats.
And is there any blood in the stool?
And definitely no blood.
Definitely no blood. So given that she has, that she's losing chloride, which of the secretory diarrheas would cause you to lose chloride? We have to look that up. And I think that Mario had thought of that early on, that this would be a very unusual cause of chloride secreting diarrhea. because this is a very high stool chloride. Normally the stool chloride would be low. So, Sean, did they do a colonoscopy?
Yeah, they did a colonoscopy. And she had a circumferential adenomatous mass in her rectum, and the biopsy revealed a villous adenoma.
Mario, you get the Brilliancy Award for the week, because in the first 3 or 4 minutes, you brought it up as a possibility. Now, I actually had read this case and I knew where it was going. This case was actually in the current issue of what's the name of the journal that I found it in, Sean?
Let's see. I have so many things open. Kidney Case Conference.
It's from
American Society of Nephrology.
Yeah, the Clinical Journal of the American Society of Nephrology. Yeah, which is actually, I think it's an interesting journal. And when I read the case, it blew me away. What I love about this case is that even though I didn't know this, it ended up having to be that. So I would love as many people as are willing to do it in the chat, write down the 2 big things they learned in thinking through this case. You know, this would be unfair anywhere except for renal boards. So this is really an unfair case, but it's a very instructive case. And I love the logical pathway that Mario and Rafa took in working through this. So write down 1 or 2 things that you will take back in working up patients, either with the hyponatremia or with the metabolic alkalosis or the hypokalemia. So Francisco, remember that you can get neurogenic pulmonary edema from acute hyponatremia. Thiago now knows, like I learned, that and could cause the chloride secreting diarrhea. Alex liked the urine studies, and I believe the urine chloride does not go up with the diuretics, whereas the urine sodium can go up with the diuretics. The secretory diarrhea differential, and that's not real common Zoom user, but it's certainly worthwhile. You should get your colonoscopies starting at age 45. I'm so far past that, Drew, it doesn't matter. Stool lights to clarifying diarrhea, yes. And yeah, the USP STF does recommend the colonoscopy. If you're not old enough to have had a colonoscopy and haven't had one, the only thing bad about a colonoscopy is the prep. I don't remember any of my colonoscopies. At my age, I've had 3, and they gave me conscious sedation, and I don't remember a single thing about them. If I was in pain, I don't remember it in any way. It's really not bad. The prep is horrible. Points of stool, osm gaps, and I thought that Drew did a very nice job of explaining that. Is it 24 hours of fasting for colonoscopy? It was less than that. It was probably about, I think I had to stop eating around noon for the next morning. And the prep is my 3rd prep was much better than the first 2 preps. So it is getting better. You do get to sit on the throne quite a bit. Dehydration, high sodium, not low, high BUN creatinine, think GI bleed. Now she was obviously very volume contracted, but Harsha, I think those are good points. pay attention to the patient's stool when suspicious. Yeah, that's a good one, Sherry. So we're going to let Rafa and Mario have the last word.
So for me, it was incredible just to revise all the metabolic alkalosis causes, especially when it comes to hypochloremic and hypokalemic causes. And also to be reminded to divide non-inflammatory chronic diarrhea in osmotic and secretory causes based on the stool-osmolar gap and the differential that comes along with that.
Great.
Well, for me, I think we got to a point where, and at least for in my algorithm for hypokalemic metabolic alkalosis and hyponatremia, the two, like they were the same differentials were in both buckets, in the chloride sensitive hypokalemic metabolic alkalosis and in the ADH appropriate ADH elevation hypotonic hyponatremia. So I think navigating through the labs helped us get in there, also with a clinical history. So I think that was for me what I learned, that that was the point of overlap between the hyponatremia and the hypokalemic metabolic alkalosis. And if I may add something, today's my birthday. I'm really happy to have really spend an hour here. I really couldn't think of a better thing to do, an hour on my birthday. So thank you.
Well, we're so happy that you joined us for your birthday and did such a wonderful job helping us think through the case. And remember, that's really the whole purpose of both this and the clinical problem solvers, is making us think better and think carefully. And you guys did a great job. Sean, thanks so much for presenting it very nicely. And I was accused of being a really good actor since I knew what the answer was all along, and I didn't, and nobody knew that I knew what the answer was all along.
You deserve an Oscar.
Yeah,
I was like, he's as lost as me, and you were like, oh no, I've already read the case, and I was like, what?
well, I wanted to stimulate everybody's thinking, and I think everybody did a lot of thinking, and I appreciate the chat. We'll see what we can come up with for next week. We have a few good cases that we're working on, so it should be fun. Y'all have a good evening.